Hello, and welcome to my clinical case presentation on chlamydia. My name is Bonnie Moon, and this is for NURU 674, Management of Complex and Chronic Problems in Family Across the Lifespan Care at Brandman University. Chlamydia is a sexually transmitted disease from an infection with a bacteria called Chlamydia trachomatis. Even though it is asymptomatic in most patients, it can cause cervicitis in women, urethritis and proctitis in both men and women. In women, chlamydial infections can lead to very serious consequences that include pelvic inflammatory disease, tubal factor infertility, ectopic pregnancy, and chronic pelvic pain. Lymphogranuloma venereum is a different type of STD caused by the same bacteria but with a different variation. It occurs commonly in more developing countries and has caused outbreaks of proctitis among men who have sex with men. Chlamydia is the most common reported STD in the U.S., with 1,808,703 reported cases in 2019 as shown in the first graph. Due to its asymptomatic nature, the actual cases is significantly higher. The second graph shows the highest incidence is in age groups 15 to 24 years of age in the U.S. from 2012 to 2019 per 100,000 persons. More women are infected at 1.75 more times than men in 2019. Rates of chlamydial infection are disproportionately higher among persons in certain racial and ethnic groups, with the highest rates among Black persons. Consistently, the South has the highest amount of incidences. Chlamydia trachomatis typically infects columnar epithelial cells in the mucosa. If untreated, a chronic infection will likely occur that can last months or even years. It has a complex reproductive cycle, as illustrated here, and takes about 48 to 72 hours to complete. Chlamydia replicates within a host cell and eventually causes death of the host cell. The risk factors that increase your chances of getting a chlamydial infection are sexual activity, men who have sex with men, women who have sex with women, a history of multiple sexual partners, being a partner with someone who has multiple partners, Black women, lower socioeconomic status, age under 25 years old and even higher when you are under 20 years old, inconsistent use of condoms, and a history of sexually transmitted diseases. The risk decreases with age and even more when you are over 21 years old. Women under 25 and older women with risk factors need yearly testing. The assessment findings for women include asymptomatic symptoms in 85%, mucopurulent cervicitis, as shown in the illustration, an edematous congested friable cervix, vaginal discharge and/or vaginal bleeding, breakthrough bleeding or spotting, Bartholin's gland discharge when milked, cervical motion tenderness, dysuria, pyuria, otherwise known as painful urination, urethritis, pelvic pain, salpingitis, a high risk of premature rupture of membranes and premature delivery of a pregnancy, and proctitis. The assessment findings for men include dysuria or urethritis, proctitis, epididymitis, prostatitis, and penile discharge. Infants are usually afebrile and can have pneumonia and/or conjunctivitis. The gold standard diagnostic test for Chlamydia trachomatis is the nucleic acid amplification test, otherwise known as NAATs. NAATs are the most sensitive test and can be performed on swabs or urine. Vaginal swabs are best for women, urine is best for men. Rectal swabs can be performed if anal sex is performed. Adolescent women can do self-vaginal or urine exams if asymptomatic and no pelvic exam is performed. There is also an Aptima assay for C. trachomatis antigen detection via cervical or urethral swabs or first catch urine. This has an 80 to 95% sensitivity compared to a culture. A urinalysis shows positive for white blood cells. A wet PrEP can be performed and should show more than 20 white blood cells per high-powered field. A culture is not typically used because it has a high cost and technical expertise is required. If a test cannot be performed, treat the patient based on signs and symptoms. With high suspicion, treatment can be started before the test results. The first-line pharmacologic intervention for chlamydia is azithromycin 1 gram oral single dose or doxycycline 100 milligram orally twice a day for 7 days, or for 10 to 14 days if the epididymitis is involved or for pelvic inflammatory disease. Second-line treatment is with levofloxacin 500 milligram orally once daily for 7 days, or ofloxacin 300 milligram orally twice a day for 7 days. Erythromycin-based antibiotic can be prescribed as 500 milligram orally 4 times a day for 7 days, or erythromycin ethyl succinate 800 milligram 4 times a day for 7 days in the event a patient cannot take doxycycline. Pharmacologic interventions for pregnancy include amoxicillin 500 milligram orally 3 times a day for 7 days with azithromycin, erythromycin base, or amoxicillin. Tetracyclines and quinolones are contraindicated during pregnancy. Children under 45 kilograms can be treated with erythromycin base. Children over or equal to 45 kilograms and children less than 8 years old can be treated with azithromycin. Children 8 years and older can be treated with azithromycin or doxycycline. Non-pharmacologic interventions include education on the serious sequelae of C. trachomatis and the importance of abstinence for 7 days after sexual partners have completed treatment. Expedited evaluation of all sexual partners within the last 60 days for treatment is an important intervention. If a child after the neonatal period has chlamydia, consider sexual abuse. Report all STDs to your local health department. Screen pregnant women during the 3rd trimester for women at risk, which includes women who are younger than 25 years old, pregnant women with new sexual partners, and or more than one sexual partner. Condoms are highly recommended for prevention of chlamydia. Primary prevention includes education, condom promotion, and condom distribution. Secondary prevention includes screening for at-risk populations, whether symptomatic or not, and the screening of their partners. Referral for expert consultation for treatment is recommended for pregnant women and children with suspected sexual abuse. When planning follow-ups, it is important to know that test of cure is not advised unless adherence to treatment is questionable. Test of cure is recommended for pregnant women at 3 weeks after treatment is completed. Patients should be retested in 3 to 4 months after treatment due to high risk of reinfection. Also, It is important to screen all chlamydia patients for HIV, gonorrhea, and syphilis. Complete resolution is expected with proper treatment adherence and early therapy. If inadequately treated, women can develop pelvic inflammatory disease and infertility, and men can develop prostatitis, epididymitis, urethral strictures, or transient oligospermia. Men and women who have an autoimmune response to the bacterial infection, known as Reiter syndrome, can cause reactive arthritis, which also can have symptoms of conjunctivitis, urethritis, and cervicitis. Fitzhugh-Curtis syndrome is a possible complication that causes perihepatitis. The Centers for Disease Control and Prevention has issued new clinical practice guidelines for 2021. After a meta-analysis and a Cochrane systematic review evaluated data from randomized clinical trials, it was found that treatment failure was higher for azithromycin than for doxycycline for urogenital, rectal, and oropharyngeal infections. Erythromycin is no longer recommended because of the frequency of GI side effects and subsequent non-adherence. If there is GI upset and non-adherence suspected with doxycycline, azithromycin 1 gram regimen is an alternative treatment option. The CDC recommends post-treatment evaluation and testing if azithromycin is furnished because it has demonstrated lower treatment efficacy for rectal infection patients. Levofloxacin is expensive, so the CDC does not recommend this as first-line treatment. The CDC has updated their treatment guidelines for gonococcal infections and chlamydial co-infections. After a review of recent evidence, the CDC recommends a single 500 milligram intramuscular dose of ceftriaxone for uncomplicated gonorrhea of the cervix, urethra, or rectum. For persons weighing above or equal to 150 kilograms, which is about 300 pounds, 1 gram of intramuscular ceftriaxone should be administered. When a chlamydial infection is suspected or has not been ruled out, treatment with oral doxycycline 100 milligram twice daily for 7 days should be administered. During pregnancy, azithromycin 1 gram as a single dose is recommended to treat chlamydia. Here are the references for this clinical case presentation on chlamydia. Thank you for watching. Here are the references.